Onc Live Insights is a video editorial program produced by Onc Live.
One of the more interesting approaches in breast cancer has been the development of inhibitors of a protein called PI3K. There's a lot of interest in this particular protein for several reasons. One is that it is commonly mutated in breast cancer. In fact, it's one of the most commonly mutated genes in breast cancer, particularly in ER-positive breast cancer, where the mutations are up to 40% of these tumors. And in addition to that, there's a number of preclinical studies that suggest that there is an interaction, we call a crosstalk, between the PI3K pathway and the estrogen receptor pathway, such that activation of the PI3K pathway can interfere with sensitivity to inhibitors of the estrogen receptor pathway. For both of these reasons, there's a lot of interest in developing these PI3K inhibitors, specifically in estrogen receptor positive breast cancer. We actually had some proof of concept that this idea may be fruitful from the Bolero trial, which used everolimus, which is not a PI3K inhibitor, but an mTOR inhibitor. mTOR is downstream of PI3K. And the combination of this mTOR inhibitor plus hormonal therapy, as I think many of us are aware, has resulted in a significant improvement in progression-free survival compared to hormonal therapy alone, in this case exemestane. So based on that, the first place that these PI3K inhibitors are being developed have been in estrogen receptor positive breast cancer, particularly in combination with hormonal therapy. The first randomized trial of one of these inhibitors was presented at San Antonio last year, which looked at an inhibitor called pictolisib that was combined with fulvestrant in patients who had had prior exposure to an aromatase inhibitor. This was a randomized phase 2 trial, only 168 patients. And in that study, there was not a significant improvement in progression-free survival, which was the primary endpoint, with the addition of this PI3K inhibitor to fulvestrant. Unfortunately, pictolisib was associated with a significant amount of toxicity, and in fact, almost 50% of the patients on that trial either had to significantly reduce the dose of pictolisib or discontinue the drug altogether. So I don't think that the negative results with pictolisib really say that this idea of blocking PI3K is not an appropriate approach to overcoming resistance to hormonal therapy. I think we are excited about a next generation of PI3K inhibitors, whereas pictolisib blocked both alpha and beta, two isoforms of PI3K. There is now interest in looking at drugs that specifically block the alpha isoform. The reason this is relevant is because it's actually the alpha isoform that is mutated in breast cancer. So we now have phase 1 data of these newer PI3K inhibitors that specifically block alpha, and these have shown fairly compelling degrees of activity, specifically in those breast cancers that have PI3K mutations, which would fit again with this idea of these drugs specifically blocking the mutated form of PI3K. So the two of these inhibitors that we've seen the most data from so far is one called tasilisib, or previously known as GDZ 0032, and another called BYL719. And again, both of these are more or less specific for the alpha isoform. And they've shown response rates in the 20 or more % range in ER-positive pretreated breast cancer when combined with hormonal therapy. At least tasilisib is now moved into the phase 3 setting. There's a trial called Sandpiper, which is being presented as a trial in progress abstract here at ASCO this year. And that's a randomized trial looking at the combination of fulvestrant plus placebo, or fulvestrant plus this alpha-specific inhibitor tasilisib. So again, I think whereas we don't have any large data sets yet on these newer generation of inhibitors. The early phase data look promising, and I think this is an approach which has a lot of potential. Beyond the work of PI3 kinase inhibitors in ER-positive disease, there's also a lot of interest in looking at this type of agent in HER2-positive cancers, and that's because there's compelling data that PI3 kinase is important downstream of HER2, so HER2 needs PI3 kinase to function, and at least in the laboratory, blocking PI3 kinase is very effective against HER2-positive cancer cells. So there is already a preoperative trial called NeoPhoebe, which is looking at BKM120, which is a pan inhibitor of PI3 kinase in combination with trastuzumab and chemotherapy. I think this is a very interesting trial. And there are a number of now phase 1 trials combining other PI3 kinase inhibitors with HER2-directed therapy. And again, at least in the laboratory, this is a very exciting approach, and I think we'll have to wait and see what happens in the clinic, but I think people are optimistic about this strategy as well. In addition to PI3 kinase inhibitors, there's also development of drugs blocking AKT. AKT is downstream of PI3 kinase. AKT itself is actually mutated in a small fraction of breast cancers, but maybe even in the absence of AKT mutation, there still may be benefit to blocking this important pathway in breast cancers. One of these inhibitors is GDC0068, which is currently in phase 2 trials, and there are other AKT inhibitors being evaluated as well.
So one other area that we're all really interested in is inhibiting PI3 kinase. And you kind of wonder, why did we start with mTOR? Well, at the time that everolimus was available and other mTOR inhibitors that didn't make it in breast cancer, the PI3 kinase inhibitors had a lot of toxicity and not high potency. So they had too many off-target effects. And so it was very reasonable to go with drugs that were already approved for other indications, and hence everolimus and Bolero-2 and approval. But then the next idea was, well, let's now go back and look at these drugs, PI3 kinase inhibitors, AKT inhibitors. We've got better ones now that we can really study in this area, both in combination with chemotherapy and in hormone therapy. My interest is greatest in combination with hormone therapy, although there's a whole area of evaluation in HER2-positive disease, and some data at ASCO 2015 that looked at, resistance to HER2-positive disease, which we well understand with activating mutations in PI3 kinase, that potentially you could overcome that with an mTOR inhibitor, everolimus, that's a group of patients that might benefit. And that would be a very good area to study PI3 kinase inhibition, really interesting, new area. But if we go to hormone therapy, where I think the greatest work has been done to date and will be seen in the near future, these PI3 kinase inhibitors have all been studied in combination with hormone therapy, much like I was discussing, much like we've talked about in many different areas with CDK4/6 inhibitors, with the mTOR inhibitor, et cetera. And it'll be interesting to see. I mean, the question is, what are we going to do when we get all this data, and where are we going to go? First, what we know so far is that some alpha-specific PI3 kinase inhibitors seem to have a better toxicity profile and high activity, whereas the pan PI3 kinase inhibitors seem to have a little more toxicity. And one drug, at least the Genentech drug, had a negative trial, and the Fergie trial didn't show benefit. And we're waiting for the data from buparlisib from the Bell trials from Novartis to see what we learn about that agent. Right now, I think the interest is really in these alpha-specific PI3 kinase inhibitors. Genentech is actively studying their agent, and also in Novartis BYL719 or alpelisib is being studied not only in combination with CDK inhibitors, but in combination with hormone therapy in randomized trials. So where we're going to go with this is going to be really interesting, because I think the next generation of trials, starting with alpelisib, will study combinations of alpha-specific PI3 kinase inhibitors with hormone therapy after CDK4/6 inhibition, because you're targeting different pathways, so there might be non-cross resistance, and that would be great.